So first of all, we have to understand what is PLIF and what is TLIF. PLIF, since 1950s, we have been performing that procedure. You take the medial part of the facet off here, and then you get access to this space here. Obviously, in that procedure, you go here through that angle. You go more or less straight down, and then you have to bypass the spinal cord dura and the nerve root both. And this proximity to both structure is actually the problem. So we found out later that if you take the entire facet off, not just the medial part, you can go a little at an angle, and that's more beneficial to literally have less neurological deficit. And that's the practice. When you take the entire facet off, this is the angle you go in. You take the facet off here and here, that takes time, but then you have much better, bigger access to the disc at that angle. And you go truly through the foramen. That's why it's called transforaminal lumbar interbody fusion, which requires us to take that bone here off. Now, obviously with the OLLIF, we are bypassing all of that, and we go completely outside and stay away from the dura, but still we are not too far away from the nerve root. But there is, this system for OLLIF is very refined. We use a neuromonitoring probe. You go there, you put that sleeve in after we are in the right place. Then this comes out, a K-wire goes in, and over the K-wires we dilate and we do the surgery. Now, if you do an open surgery, the problem with the TLIF is that first you have to take the entire facet off, but then you have to go to that space. We call that the epidural space. It is not empty like this. It's lots of veins. As a matter of fact, vast majority of the bleeding in the TLIF happens when you are preparing that space to get access to the disc base. And obviously, based on studies, up to 5 to 7% of the time when you do this kind of surgery, you injure the skin here. We call that duratomy, where then fluid of the brain, CSF, comes out, and then you have to sew. It's a big mess when it happens. Now, we have something that's hybrid between the OLLIF and TLIF. You still take the facet off, but then you don't go and try to get all the stuff out of here and prepare that space like you would do, because it takes time, it's bleeding there. What you do, you do use neuromonitoring probe. And imagine now the facet is off. We go there, we just want to be away from, it's not the OLLIF angle, it is truly transforaminal angle. The facet is gone. And then we go there, literally, we just need enough space for the tip of this. And by going there after the facet is off on the pedicle, we position it in the typical transforaminal approach. And then we go in. Again, this is not OLLIF, this is truly transforaminal. Then the K-wire goes in. And now this is the magic of tubular TLIF. This place is full of veins. Again, in a regular surgery, you go with the bipolar, stop all the bleeding to get the approach here. But instead of doing all of that, now what you do, you put the dilator, and the dilator, when it goes in, tamponates all those epidural veins. So you don't have all the bleeding of a regular TLIF. And the angle is still transforaminal. And obviously, by doing it this way, you get within a second access to the disc base, and then the actual magic starts as well. You remember that in the regular TLIF, you put the dura and the nerve root at the danger, because you go with the sharp instrument 50 times in and out. Here you don't. Once you have the dilator in, you have tamponated the epidural veins. Now you go with the tube in, and now this is still a mini open, MIS, TLIF, or open even. Dr. Kim does it all the time. Now you have access to the inside of the disc that's protected by this tube against the dura and the nerve root. Now you can go 50 times with your sharp instrument. Not actually, you have to make sure that stays there, but then you don't have to go with the sharp instrument 50 times in and out, bypass the dura and so on, and still everything is tamponated there. So you don't spend a lot of time, you don't have a lot of bleeding to just stop that bleeding. You get access faster, and the dura and the nerve roots are protected. According to Dr. Kim, that's for every level, that saves about 250 cc to 350 cc of blood, because most of the time that's what you're spending time to stop that bleeding, get access there. And as well, in this case, you don't really need to visualize the nerve root, because when you go with the probe, you know you're far away from that, and then the rest is dilation that pushes actually nerve root up when it dilates the disc base. And now, practically with the same set that we use the OLLIF, we go through that tube, perform a discectomy, prepare the end place. Once everything is done and the end plate and so on is properly prepared, we put the K-wire back, and then we put a little bit of a thrombin gel foam or Surgiflow here, because once you take that dilator out, it may bleed a little, but then again, it's a low pressure, like 4 to 8 centimeter of water pressure, a very low pressure venous bleeding. So a little thrombin gel foam or Surgiflow will stop it right away. And then this is the OLLIF cage, which is on dilator, the arrow cage. And then the arrow cage then can go exactly like the way we do it with the OLLIF. Go over the K-wire, be its own dilator. You even can, go first this way, go in, then rotate it. Or you can go with a smaller cage, you can go even straight in and position it exactly the way you do a transforaminal lumbar body fusion. So practically, it's a true TLIF that can be done in open or MIS TLIF fashion. The difference is that after you take the facet off, you don't visualize the entire disc. You just visualize enough of the disc to put this in, then use the sleeve, put the K-wire, dilate, and then you do most of your work over a tube that is inside of the disc. That is the difference between this and MIS TLIF. In MIS TLIF, you use a tube, but the tube stop at this place here. From here to the disc is still almost like an open traditional surgery, and it's a small space, and that can sometimes, for some people, especially in the learning curve, can be longer than regular TLIF, because you have to work in a smaller space and so on and so forth. And according to Dr. Kim, that saves a lot of time, a lot of reduce significantly the bleeding because of the things that I discussed. Do you have any questions regarding the tubular TLIF itself? No? Okay, thank you.